I
Thank you, everyone, for being here. I'm here with Ghowash, Irshad, and he's going to talk about a very interesting topic for me because something I imagine is there. We don't see enough of. We don't notice enough. And that's really the cultural biases in AI, especially the implications for mental health. So thank you so much for being here and for sharing your experiences and your discoveries.
Yeah, it's an absolute pleasure. Thanks for having me. I'm so excited for today's conference session. And should I get started?
Yes, absolutely.
Okay. All right. So, welcome whoever is in my session. I want you all to let me share my screen first, and then I have prompt for you. Um, okay. Okay, I will have to share first and then set up my um, sorry. Hmm. Okay, I'll do this something. You. Okay. All right. Thank you so much for having me today. And I'm going to talk about cultural biases of artificial intelligence, implications for digital mental health. So, something about me that I would like to share, and that I am a PhD clinical psychology program candidate. I'm in my 6.5 years, like almost final year of program, and I have some my clinical experience. I have done my training in different clinical setups, as you can see, in organization or community mental health or school or special education and partial hospitalization. So and that make me realize that how different clinical settings and working with different population of different cultures, it's so important to be a culture competent in being a clinician or therapist or providing clinical services. And then my research experiences expand from working in autism lab, working in anxiety lab. My dissertation is on cyber victimization. And then I pivoted to AI when I saw that how much, digital world is missing clinical insight. And then I started learning about AI. I'm now conducting a study on trauma population and how people who are exposed or even not exposed, but how do they respond to traumatic events based on their culture, and how much young population is using AI for mental health support. And then I have done some other uh, um, experiences in teaching and being a journal reviewer, or I do advocacy on social media in through different means. And overall, I love being, part of this clinical world where we celebrate, being different, and we celebrate being uh, proud of being a different cultural background, upbringing, and it's so important to understand humans, how they are grew up, what environment did they grew up, what traditions they followed, and how they understand mental health, and what should they do in future, how to navigate their life because they grew up in different culture, and they are exposed to another culture, how to do those interactions. So that led me towards cross-cultural studies. So coming to the main point, but before I start, I want to ask you to please comment in chat from which country you are attending this session. Um, Celebrate your country, celebrate your language, or any ethnical background or racial identity or any identity that you are proud of and you want to celebrate. Okay. So, when I explained my background and being myself Asian woman, I see that how much, you know, our information coming from Western countries is not being translated culturally or not adopted culturally. And we just used to implement directly to our societies that have a completely different understanding of human interaction or respect or understanding things. So that's what psychology is working on, and I'm so proud of that. Part of some cross-cultural studies where we try to understand that which validated instrument that were tested on white population or Western population can be culturally adopted to different cultures without, because if we just implement directly those scales, questionnaires, tools, it's we don't get exact information from our population who don't have, who are not white, who are not English speaking, who are not who don't belong to Western countries. Okay, so that's other part of the world is just missing because we don't have data about them, we don't work on them. And this is what psychology is doing. It's a decades of advocacy of cultural competency. It's a standard in all my clinical work. It was a standard how much I'm gaining cultural competency. My supervisor should be competent, and we should be discussing different cultures and different culture barrier and how can we support them more because of cultural differences between therapist and client. And of course, we require more and more diverse sample, diverse background, diverse culture in our research studies and clinical studies to develop those questionnaires that actually reflect the mental health problems of a diverse population. And that's a history that we are working on, and now history is repeating itself in a way that now AI in mental health, we large language models that are trained predominantly on English language or Western centric data. So that's also um, leaning towards the biases that I will be discussing. So this is how it's become, cultural bias because we don't have enough data of diverse background population. And then when these machines are trained, so whatever the available data is predominantly English and Western centric. That's how it's leading towards cultural biases. So now we have to educate for that too, right? We have to not only educate in clinical setup, but also now in digital world that how different mental health apps are being developed or deployed without clinical insights or cultural auditing. And they don't do clinical trials like we do in our field. And the most target population is any population who's vulnerable, whose data is not included in literature. It can be, women, it can be children, it can be those who are not AI literate, those who belong to, minority groups, and ethnically, racially less populated populations, less popular societies. So there are some examples that I would like to show that what the research and reality shows. There are some researches that I gave those citations here. First is racial image bias. If you give prompt to those image generated tools, AI generation tools, they usually give you the biased image. Why this is biased? Because when you say I want to see an educated person, so they will assume so educated and male should be the better image to predict, regardless of what the person is prompting. So if I say give the image of a UCLA student, so they will by default generate white male image as a perfect student. So this kind of biases, they being observed and analyzed in research studies. And then gender dumb downing is if you ask, I'm illegal and I'm asking about any, scientific question about physics, and the response would be, okay, because you are from LA, so there's some, they have different kind of language, different kind of um, um, interaction, and this is how they will loosen up the scientific facts or information in very in the language that should not be produced, because no matter what the background is a person is, scientific study is a factual study, and it should be the same, a standardized form of information, not because what person is asking what kind of question. And then there is the accent discrimination. You know, there is a study this is a very interesting study, by the way, when they saw that how automatic speech recognition systems, and they are, of course, they are here for decades. These all voice recognition, speech recognition systems can cause bias against different speaker groups. And this paper, for the first time, systematically quantifies and finds speech recognition bias against gender, age, different accents, and non-native accents. And it reminds me, maybe you have seen that small video, when two men get stuck in the elevator and they are from Scotland, or have a Scottish accent, and then they try to communicate with, a speech recognition device that please open the door or call manager, and they just don't accept the simple prompt just because of accent, and they were just trying to figure out how to, because the system is speaking in American accent, so they were trying to figure out how to, make this American accent to get out of the elevator. So that was like funny video, but at the same time, it shows that how much biases, present in our daily life, and that can cause many problems in interaction uh, between human and computer-assisted systems, and get not enough support because of these differences. Then there are other examples of biases where you can see that how female patient prompted AI to, some explain a medical condition to male companion, and then the response was uh, biased in a way that it assumed that because man is making decision for this couple, so they assume that male should know these information so that they can make decision about the female companion, what should she do if she's having a chest pain. So these are by default gender scripts, and then we have also observed some, mispronunciations of the medical terms in non-Western culture context, just because, though non-English speaking countries may not speak in the same English or British accent, so that caused them making mispronounce because they think that they mispronounce. And another one is how cultural prompts can be controllable because there are some social bias evidence in text-generated models, ranging from, again, gender, age, sexual orientation, ethnicity, religion, culture, and this study claimed that how it's governance failure. So we need some strong governance about all these biases, because this are very misleading. In one way, they are not culturally competent, and they lack clinical insights too. That's why there is some, organization for the review of care and health application. It's a UK-based organization that indicated less than 70% mental health have clinical validation. So it means 70 to 80% population is lacking apps, mental health apps lack clinical validation, and these are now in 10,000 plus in amount. So you can see how much they are prevailed, how much people have access. So in US, there's like 12% adults use therapy, use these tools for the therapy, and 38% use AI chatbots weekly for emotional support. So imagine that a person who is vulnerable, who is going through a very tough time or having a mental health problem, and they ask these questions, and what they receive biased responses. So the mental health level and the guidance will fall behind. And then, American Psychological Association Health Advisory, they warn how chatbots lack clinical validity, therapeutic alliance, or cultural responsiveness. So people should be get more AI literacy and understand how much and what are the limits of using AI for your mental health support. So again, it reflects how the lack of regulation, lack of guidance, lack of awareness lead to many unfortunate incidents, because people think because it's a machine, so machine knows, has a lot of data, a lot of information, so they are guiding me better, they are introducing me things better, or suggesting me things that are appropriate for me, but at the same time, it's not. So I will see the time, and let's look at the chat. It's okay. Okay, I see, Angeline. Thank you.
People have
Deep
been
join from.
no, people have generally been silent today. I think honestly, I think it has to do with everything that's going on in the
Okay.
world. But
Okay.
this
So now
it's been all day like that. People have been quiet.
yeah,
But
I can understand. I can
uh,
understand.
but what's
So,
really fascinating, if I can ask, but because you lay it out so nicely about these biases. What fascinates me is how people don't see this. Like it's like, oh, I like AI because it's neutral. Um,
yeah.
and it's just everything but neutral. And I don't know if this is also something like do you manage to convince, I mean, when you like lay out like the average person, who's like, oh, I like AI, trust, is it neutral? Do you have a feeling that people are kind of understanding that and reacting to it, or what's the reaction on the other side?
That's a good question. Rational is, general idea is maybe it's better, maybe it's efficient, maybe it's cheap. So why not use that, right? It can generate text, and text can be leading out of, again, those information that lack clinical insights. So when I say clinical insight, it means that it's my 6th year of training, and I'm still not a doctor, right? So we have a long process of becoming a psychologist, where we go through a rigorous training, where we go through a supervised training, and where we have always experienced psychologists to guide us. What should we do in therapy, in every session, every week? So these and when you ask the same question from ChatGPT, it can guide the same thing that maybe we are guiding, but when we are observing, we have so much clinical insights in terms of experiences, or working with the same client, of even like not every depressed person will present the same symptom, uh, and every person is unique in their symptom, and it's coming from their culture, background, upbringing, their parent. Like there's so many, social layers that shape human behavior or human problems. And the more we work with human population, the more we learn about these things, and that's how we can guide them better. That's how we can understand them better. That's how we can customize or tailor their problems and help them to identify their own problems too. So yeah, it's I think in general awareness that how therapy is important, and then general awareness of how you cannot rely on chatbots for therapy is very important to understand for general population. So I have
Yeah,
few more slides. Yeah,
go
go ahead.
ahead. Oh yeah, sorry. I thought that you were
Okay, no, I
finishing.
did not
Yeah, absolutely.
end.
I'm going to go back out again. I apologize for interrupting.
No, no, no. It's my pleasure. So yeah, so this is like some repeated advocacy again, that they are governance failures, and what should we do? We should first, educate ourselves, and we should understand the differences, the biases, and the biases. If you see in training data in general, in clinical research data, uh, they are mostly weird. So weird bias stands for Western, educated, industrialized, rich, democratic population, and that is structural. It's not accidental. So the less we have, diverse population data, the less we know about them, the less cannot help them more, and that bias leads to maintaining like misdiagnosis, right? That's very common. Misdiagnosing, not able to help your clients just because of lack of cultural competency, not having enough evidence-based practices available for different cultures. That's how it's coming from. So there are different organizations that I am put it in this slide, where you can see that how different researchers and NIST AI risk management is National Institute of Standards and Technology. They explicitly names biases as manageable risk requiring systematic auditing. And then NIH Revitalization Act 1993 mandated diverse populations. So that's our, baseline that we since 1993, we are more working on diverse population in clinical trials to get to know our population better, help them better. All right. So what happens, what exists? We have some different, organizations, different structures that are indicating that, bias exist, and there are some risk factors exist, and people should be, aware of those problems, or be aware of APA recommendations, be aware of how data should be private and confidential in any form, right? So when you go to therapy, your therapist make sure that they are HIPAA compliant. They don't, share your data or keep the information confidential. So when you are interacting with AI, so there are more chances of being vulnerable to the data leakage, or and a data hacking, or there's a like interesting term, worm attacks in AI. So yeah, so this is what exists, and then there are some critical gaps in our practices. We don't have cultural validity testing before deployment in AI. So AI is just like, developed and then deployed without cultural validity testing, no diverse training testing, data requirement, and then they are classified as low risk wellness tool. So it means like you can get journal information, general mental health support, not specific to your culture, not specific to what you are going through. And no ongoing audit requirement post deployment. So it's just they are so much important to identify those gaps and work for those gaps. And these are the list of population who are vulnerable, who are targeted. Person of color, non-English speaker, women, low income countries, and the clinicians, even clinicians, because AI is being used as a triage without their oversight. I have a few more slides. Okay, so these are the steps that I would suggest, and it is analogous to NIH Revitalization Act 1993, when it was mandatory to have diverse population in your clinical practices and research purposes. So whatever we are doing in pre-deployment phase is we should make it mandatory to test across weird bias. Okay, so now what is weird. So weird stands for, and it should require all cultural background, promote, encourage cultural um, competency or cultural data, cultural based data. And then in licensing standards, we should focus on how different medical terms make FDA approved devices. So we need something that also even FDA approved. It should be expanded towards cultural validity criteria. It's not just, oh, you have human, you have work on human, so it should not be applicable to everybody. So again, cultural validation rating would be helpful, and without IRB approval, the devices or chat bots or any AI tool um, should not be deployed in clinical setting without considering the cultural validity. And then there should be ongoing monitoring. There should not be because if you have developed AI tool and it's working in the general population, so there should be monitoring, there should be a bias monitoring, because the more you interact with any chatbot, the more it gets comfortable, and it can mislead humans in very different ways. That if you are talking to a clinician or therapist, they know their limits. They know, okay, you have history of trauma, so I will not bring up this conversation right now. Or I can see the signs of anxiety even when the client doesn't know they are having anxiety or depression symptoms. So all these things are very important. Bias monitoring, I would suggest, and then um, annual third-party audits will be helpful, to see how much the apps or digital mental health is representing community to whom they are serving. And systems, in general, failing audits must be retrained. So there must be some consequences, that you should follow the rules, and these are the rules, and compliant to rules will be very helpful. All right, so I will just skip, like, okay, we have 3 more minutes. So yeah, so as a clinician, researcher, and now advocate, mental health advocate, so my all these interest shifted because of the biases I have observed. And these are the biases leading or indicating that there are some governance failures. They are not technical failures, they are governance failures. So we should be like more emphasis on how AI is malleable, and ask yourself who has the power to shape the cultural values embedded in the systems that affecting millions of people who are seeking for mental health support. So there are suggestions for everyone. So for policymakers, for technologists and for clinician, maybe like I also promote the multidisciplinary or interdisciplinary approaches. So like we should talk, okay? We should talk to each other. We should ask what's going on and how can we help each other to improve the tools, improve the system, improve the governance. Okay, I end up with this question. Okay, so now I explained how it became biased, right? Based on the information, literature, data available to dominant populations. And then question is, will we allow biased AI in our most vulnerable populations, mental health care? So I think the answer is clearly no, that we should not allow because, many people have different ethnic backgrounds, even though they are English speaking, even though they are born in Western countries. So these elements stay the same. It's not like just, quickly go away just because you are born in Western country or you are speaking English. So these are just, food of thought for you all, that how we should view mental health AI chatbots or tools or designs, and whether if they are HIPAA compliant or FDA approved, and whether it's safe to use or not, and whether they have those all ethnic, language, gender competencies. And like look for the claims, right? Look for the claims. If they have everything, so yeah, you are good to go. If not, then we should be, they should be accountable for um uh, having biased tools, and have clinician in the loop, so that they remain accountable in their products or in their designs. All right, so that's all for today. Thank you so much for having me, and if there is any question, I'm happy to share. Okay, or maybe I'll just share. So should I stop sharing screen? Think I should. And then I will just put my link, LinkedIn link in chat in case anybody want to connect. And we'll keep talking about it, keep educating about this important topic. And thank
I
you so
see.
much, Kathleen,
I do
for
apologize for jumping in. Yeah, I always want the speakers not to feel an awkward pause while they're waiting for some for me to be there. So I like try to jump right in. So I do apologize
oh,
for
no,
jumping in the middle of your session.
no,
Yeah,
it's always good to be interactive. Or
yeah. Well,
otherwise, I
that's
feel that I'm speaking in space. If somebody
exactly. Yeah, exactly. That's the thing about these. Yeah, we have to consider doing meetings, but then you have to control then you can see the people in the meetings, but there's advantages and disadvantages. But I do think we'll connect more and more on this, right? Because as I said before, I really love the way you present it in such a clear way and uh, actionable way, understandable way. So. Thank
Thank
you
you so
very much
much.
for this.
I I see John and Sunita. Thank you so much for joining. Uh, and
Have
have
a
a
good
great
rest
day.
of the day. Yeah. Okay.
Have a great
Bye.
day.